Good afternoon. It's a real pleasure and honor to be here in Hong Kong. Thank you, Dr. Sito, for the kind welcoming words, and also our colleague, the moderator. And a special thanks also to the public health here in Hong Kong for the organization of this meeting and welcoming us here. So in this presentation, I think that we cannot avoid, before anything is said, to recall all of us that we are now, this week, in the World Antibiotic Awareness Week. So as here, already having this symposium and many discussions in many other countries all over the world, we are having several types of celebrations, discussions about AMR. And please, the website is there. There are very, very interesting materials, new posters, new materials to help campaigns in countries. So in this presentation, I would like to invite you through the journey of what has been the development of the WHO Global AMR Surveillance System, GLASS, the summary results of the first GLASS report. I would just touch some preliminary results of the second report that will be issued in January next year. And also, I will provide some summary results for the first report on antimicrobial consumption just issued yesterday. And then, towards the conclusion, I'll give also some sense of what will be the future development of GLASS. Well, first of all, I think that we need to remember, although everyone has said already, mentioned surveillance is needed in order to understand what is happening, to drive actions, to inform actions, we have all to remember that the WHO Global AMR Surveillance System was created as per request of WHO member states. So the same year, the same World Health Assembly in 2015 that approved the Global Action Plan on AMR also requested the WHO to establish a global AMR surveillance system. And so talking about from starting some action, this is already an action of the Global Action Plan. And in order to do this global AMR surveillance system, actually the main objective, the moment we started developing, was to see that, well, some in terms of AMR surveillance is being done, but yet in a very fragmented manner in many countries. So I think the main objective was really to foster national AMR surveillance systems, but using harmonized global standards. Very frequently we would see different standards being used, which would not help give a global picture. And then to monitor trends, to detect emergence of resistance, but also to inform on the estimates of burden. You can see here in this illustration that we have several, not bubbles, but several hexagons that talking about different types of AMR-related data. It's true that GLASS, as an initial point, the starting point, is and has focused on human antibacterial resistance. But we do acknowledge the other very important types of data, including the drivers of AMR and bacterial resistance in humans, such as the antimicrobial consumption and use, what is happening in the environment, what is happening in the food chain, and even other types of AMR, such as AMR in fungi. We also then are increasing more and more and creating also untreatable infections. So we need also to start expanding little by little. But as an initial step, we focused on bacterial infections in humans. And in a very succinct manner, I think that these 4 blocks of work, they summarize the steps for the development of the global system. The very first one, as you can see on your right, the global report on surveillance of AMR that was issued in 2014, In fact, this report was a report looking at all forms of AMR surveillance, what was being done in countries, and not only bacterial resistance, but other types of AMR surveillance, such as in malaria, HIV, influenza, tuberculosis. So, in the end of the day, the main conclusion of this report, this first step, is that indeed the standards and the road for AMR surveillance in malaria, tuberculosis, HIV infections, these were well paved and ongoing. But in terms of antimicrobial resistance surveillance in bacterial infections, acute bacterial infections in humans, there we had a problem. No much standards, global harmonized standards, but even worse than that. Most of the times, the surveillance activities, it was about a collection, information on a collection of isolates, without much information on the humans carrying those isolates. So this was quite important and created a big difficulty in order to understand what is the magnitude of the problem in the population of humans. So this led a lot the development of the second step, the GLASS manual, that established then the standards for acute bacterial resistance surveillance in humans. It was 2015. We launched the global system with the country enrollment in March 2016. And now, this last phase, in addition to consolidating the routine AMR surveillance, we are also going towards some special studies to also inform on the burden of disease and inform development of surveillance in low or limited resource settings. Okay, now where we are. So since the start of the enrollment in GLASS, and I would like to emphasize that although member states requested the WHO to establish the global system, the enrollment is on voluntary basis. So countries volunteer to enroll. And the first step is just a national commitment from the national body. Then after this step, they may start sharing information on their status of national AMR surveillance system, and eventually, when available, share data on AMR. So, as you can see in this map, we have 70 countries, 70 countries, currently participating in GLASS, and another 5 countries are in the process of enrollment. And we are looking forward to more countries to join. Just another aspect here. You know, I think that what I like about this slide is that when we started this system, initially we felt that perhaps the low-income countries or lower middle-income countries would not really be participating from the very beginning. But this is not being the case. Actually, 60% of the countries enrolled in GLASS today are low or middle-income countries. So this is very, for us, and it's been quite an intense work with these countries to improve also the systems that they are developing. So the participation in GLASS actually can bring some benefits also for countries. So, of course, the main benefit, global benefit, is to have the global picture of what's going on. But the countries participating in GLASS also have access to a series of tools to support the further development and implementation of their own surveillance systems. And also, the other aspect is that the countries participating in GLASS, they also contribute to GLASS because they inform the further let's say, refining development of the system. So it's a two-way dialogue. But what are the data that GLASS collect? There are 2 types of data. I think this is important. Sometimes when people think about AMR surveillance, we want straight to know about the rates, how frequent it is, what is the proportion of residents. But In fact, we also need to know how countries are moving regarding the development of their national surveillance system. So the very first type of information is the status of national AMR surveillance system. And I will show to you just some of what we mean by these indicators for a national surveillance system. The second type of data is the AMR data, and it's really based on priority specimens. For this phase of GLASS, only 4 specimens are being targeted, and also getting population data. I mentioned to you that in our 2014 report, we could see the lack of relatedness between the isolates and human beings carrying those isolates. So now it is true that as GLASS is asking countries to bring together microbiological information and epidemiological information, very simple, it's age, gender, what is the infection origin, it is being a challenge. But countries are walking the path and are providing data following these standards. In terms of the specific GLASS indicators, I mentioned that we elected for this beginning 4 sites of infections, and in terms of pathogens, 8 target pathogens, and these are basically pathogens that cause common community and hospital infection, and are pathogens for which we are really running out of treatment. The third criteria for choice of pathogens was also to have some pathogens that are common to the food chain, already thinking about common indicators for the integrated One Health surveillance. So this table is available in our documents, but I'd like to call attention that as GLASS has been designed in cycles of 5 years, the first year is being 2015, the 5th year is 2019. We will be revising some of these indicators. We anticipate some additional indicators to be included, but this we'll discuss more tomorrow during the workshop. The first report that was issued in January this year, it really told the story of this very beginning of the development of GLASS. It explains more on the methodology, but particularly on the limitations of the current available data, even if following the standardized methods. There are still many limitations, and we need to read the results carefully, not to be misled and take premature conclusions. So in this report, we had 42 countries participating. So the 42 participating countries in July last year, they provided information on the status of development of national surveillance system, and only 22 countries out of the 42 could provide some information on rates. Now, just going through very briefly some of the indicators in terms of status of national AMR surveillance system. Here, I think the discrimination here is by WHO region, and AMR in this second bar does not mean antimicrobial resistance. It stands for the WHO regional office for the Americas, so sorry for this acronym. The first one is the regional office, the WHO African region, then the Eastern Mediterranean region, European region, Southeast Asian region, and the Western Pacific region, and this is where we are. But what it shows is that in the end of the day, in most cases, you see here the orange part of the bars, they have some surveillance system, but no budget defined. So the question is, how can they run the surveillance system without having a defined budget? So this is an issue that in terms of investment in interventions for AMR, we need to think more and more what must be invested to get these systems. The second indicator is related to the existence of evaluation and quality assurance in laboratories. And again, you can see that it can vary a lot. In the African region, quite a big number of the participating laboratories do not yet have EQA program. So, and that can talk to the reliability of what is tested in these labs. Now, just some summary results in terms of the numbers. You can see I mentioned to you that only 22 countries provided data on AMR rates last year. And this is data for 2016, reported in 2017. So in the end, we had information on just above 500,000 patients with infections in different sites, being the most frequent site of infection, urinary tract infection, followed by bloodstream infection. Most of the sites were hospitals, but we managed also to have some sense of what is going in the community through outpatient clinics. And this table, sorry, it's a very busy table, but what I'd like to call attention here in terms of the pathogens in blood, urine, stool, in genital tract, of course it's for genital tract, it's only Neisseria gonorrhea that is being looked at, but for especially the blood side, I call attention to the main frequent pathogens, Escherichia coli being the first pathogen, and Staphylococcus aureus. And we'll come back to this later in this presentation, but just to have a sense of the most frequent pathogens. And the other thing that I would like to call attention, if you see the last column, is the proportion of isolates without testing for antimicrobial susceptibility. So, and you can see that the proportion is still quite high in some cases, like, for instance, Salmonella or other pathogens, more than 10% of untested pathogens. So it's not just having the isolate, but also knowing what is the profile. And this even busier table gives you also a sense in terms of the pathogens that have been surveyed, the main examples of types of infections. And here you can see the number of countries reporting on these pathogens and sites. But the point here, you can see quite a big variety, a big range, a large range of data that is informed from these countries, from 0 up to 91%, for instance. So this just shows that for the time, it's a limited number of patients, and therefore information should be taken with caution. I was just call attention to here to another type of metric that we are trying to get, which is the incidence. And this does require some sense of denominator. Last year, only 5 countries provided this information in terms of total number of patients that have been tested for that specific type of infection. And then this just gives you a sense of what it can give to us in terms of having the distribution per age group, per gender, and also origin, community or hospital-acquired infections. And the second one also, as a result of this information, we can have the incidence of by type of pathogen, in this case is bloodstream infection, in the community and also in the in hospitals. And then we see here also the profile of antimicrobial susceptibility test is totally different from a community versus hospital. Here is Escherichia coli being the first pathogen, again in hospital bloodstream infections as well. Now, a just a glimpse at the 2018 data call that will be issued in 2019. The main point here, the good news, is that we have actually more than 3 times the number of patients involved in this call. We had 22 countries participating, providing data last year, and this year 48 countries are providing data. So it is growing, and that also, just in this slide, we can see also the distribution of capacity to provide data according to the level of economic development. And what I call attention in this slide is that despite the fact that last year 13 countries could not provide any data on AMR rates, this year they are already being able to provide this data. So this shows the progress within each country in their capacity for AMR surveillance. And likewise, we also had more countries providing denominator data. Now, it's not only, GLASS is not only about antibacterial resistance in humans. Just calling attention, I promised you that I would provide some information on the consumption, and this is about the just launched report on antimicrobial consumption. So 65 countries provided information to the WHO, and you can see at a glance the countries with information. And the key results for this report is that there is quite a great variation of the quantity, the amount of antimicrobials consumed in these countries. But in the end of the day, the most frequent were amoxicillin and ceftriaxone for parenteral drugs. But in the end of the day, it was also noted that the last resort antibiotics were not reported in most low and middle-income countries. So there is a widespread use of antibiotics, but the access of the more advanced antibiotics is still very limited. You can have all this information online. Everything is available country by country. And we are just now in the phase of consolidation and additional modules, functions being incorporated into the global system. So concluding, I think that out of this presentation, the points I would like to highlight is that, number one, the global system can only exist if countries participate in the system to provide this global picture. It is true that many countries are facing huge challenges to build their own systems, but at the same time, they are making efforts and they are already producing data. But we do need to improve the data in terms of completeness of the information. There is, I think that it's important yet to keep insisting in assessing what is the frequency by age group in order to identify the populations at highest risk to then have the mitigation strategies. And last but not least, we do need to consider that this is really, we are in the baby steps for the global AMR surveillance system. And the more countries participate, the stronger it will grow. And we hope that it will be an important tool for this and also for future generations. With that, 谢谢。